1990. It was previously known as acute myocardial infarction, that's all. Or it was known as angina pectoralis or angina or ischemic heart diseases. These type of terminologies were used. The problem created when the whole world is involved with American Heart Association, and WHO recommended that the American Heart Association should do something about these emergencies which are lodging in the different parts of the world, Japan, Nigeria, etc. When the person comes to the emergency department with a chest pain, what is the pain? It is ischemic pain or the non-ischemic pain. If it is ischemic pain, what is the underlying pathology? What is the type? What is the variant? If it is non-ischemic pain, they usually refer to the other departments. So though the terminology used for this chest pain when the patient arrived, the acute coronary syndrome. So it is a constellation of symptoms related to the obstruction of the coronary arteries, with the chest pain being the most common symptom in addition to the nausea, vomiting, diaphoresis, etc. Now chest pain which is concerned for the acute coronary syndrome is often relating to the left arm, to the angle of the jaw, to the chin, pressure-like in character, and associated with the nausea and vomiting and sweating. Chest pain is often categorized into the typical chest pain and then the atypical chest pain. We will discuss afterwards what do you mean by the typical and the atypical chest pain, or typical angina or atypical angina. You know the coronary syndrome, coronary circulation, The coronary arteries are there. Left coronary arteries is divided into two. First one, which is the terminal one, which is supplying the lateral wall, is left circumflex artery. One which is moving on the anterior part of the heart, it's called anterior descending artery. It is the main artery of the heart, which is supplying the left ventricle. These are the branches of the left coronary artery. The right coronary artery is running on the inferior border of the heart, and it is supplying all of the inferior wall of the heart along with the posterior part of the heart, most of the posterior part of the heart. 80% of the posterior part of the heart is supplied by the right coronary artery. Right coronary artery is also supplying the sinoatrial node and AV node in 70% to 80% of cases in most part of the world. So this is the importance of the right coronary artery is concerned. Important thing is this, to understand the ischemic event of the heart, this circulation should be in your mind. And these are the main supply of the heart. But second point is important is that these arteries are communicating with each other. For example, the left circumflex branch is communicating with the branch of the anterior descending artery, or anterior descending artery is communicating with the right coronary artery, or right coronary artery posterior branches of the heart is communicating with the left circumflex artery, etc., etc. So they are communicating with each other, and this communication is very important, because if some vessel is blocked, then the supply can occur from the other side. This is one type of the circulation. The second type of circulation is from epicardial vessels. Epicardial vessels are the vessels which are supplying the pericardium. They are coming from the internal thoracic artery. They are not related with the coronary artery. They are not arising from the coronary arteries. Now, pericardial arteries are also communicating with these vessels. This is second type of a communication. And the third type of communication is from the extracardial arteries. It applies the arteries which are in the thorax, for example, intercostal arteries, and the phrenic arteries and other arteries which are very, very close to the heart. They also give branches to the heart and they communicate with the heart. This is the third type of the communication. There are three types of anastomosis in the heart. Now, this anastomosis depends upon many things. Number one, age. More is the age of the person, less are the chances of this communication to develop. Two, it also depends upon the lipid profile of the person. It also depends upon the comorbidity of the person, whether the person is also suffering from the diabetes mellitus or not. It also depends upon the non-sedentary habits. It also depends upon the dietary habits of the person. It depends also upon the smoking and the alcoholism and other addictions. So more are these are the risk factors, less are the chances of the communication. The only thing in which the communications are better is the physical activity. More is the physical activity or the satisfactory physical activity, more are the chances of the communications between these vessels, which I have just elaborated in front of you. You are safe from the heart disease. If you go for the exercise, and daily exercise is needed according to the American Heart Association, it should be 1 kilometer at least per day. It is at least per day, 7 kilometers per week. Now this will develop the communications. Now the variants of the acute coronary syndrome, because it is confusing terminology, a person is called the ischemic type of a pain. It is decided, for example, by the casualty medical officer. So depending upon the clinical presentation, upon the electrocardiogram, and the presence or absence of the cardiac enzymes, it is of three types: ST elevation myocardial infarction, non-ST elevation myocardial infarction, or it is unstable angina. Now these three types of the variants of acute coronary syndrome are very important, because the morbidity, further morbidity and mortality depend on the type and the variants and handling of the patient. Now, so acute coronary syndrome, first of all, which we decide is the clinical presentation. It is done. There is a chest pain, which is it is looking very, very typical chest pain. You have done the electrocardiography on the 0 hour, after 15 minutes, after 30 minutes, after 1.5 hours, etc. And you find that there is no ST elevation. If you find there is no ST elevation after many ECGs, then you go for the enzyme. If the enzyme is positive, it is the non-ST elevation myocardial infarction. If the enzyme are negative, then it is called unstable angina. If the ST elevation is there clear cut and enzymes are positive also, then it is called ST elevation myocardial infarction. At one time, it was the ST elevation myocardial infarction was called Q-wave infarction, and the other one is called non-Q-wave infarction at one time. But nowadays these terminologies are changed. They are no more used, these terminologies. So the acute coronary pathophysiology depends upon the stability of the coronary vessels. I have already said that. The stages are seen in this diagram, how the coronary artery is obstructing. The first one is the brunt of the blood which is flow, that is the flow of the blood inside the vessel, which causes the minor trauma always. Secondly, it is the lodgement of the LDL cholesterol between tunica media and intima. And tunica media and intima, if it is lodged with this LDL cholesterol, it is called the foam cell there. The foam cell will enlarges and it will form what is called plaque, coronary plaque or plaque. This coronary plaque will obstruct the vessel more and more. If it ruptures or it enlarges, it will block the vessels to a very high extent. In 50%, if there is block, nothing happens. Other than if you run very, very quickly, then there will be symptoms. Otherwise, there will be no symptoms. If there is 70% blockage, there will be angina occur on effort, or angina occur at the slight exercise. If it is 90% blockage, the blood is insufficient to supply the heart if there are no other way to supply. The other circulations are not there. The communication is lacking. Then that area is supplied by feeding area supplied by that vessel is going to be necrosed. This is ischemia. It will cause infarction in the end. This is how the pathophysiology of the acute coronary syndrome is described. Atherosclerosis is the main problem. It is a part of the disease. Starting normally it is fatty streak, and then I said it is the fibrous plaque, foam cell formation, and fibrous plaque, and then calcification can occur and total blockage can occur. These are the stages which are seen in front of you. Start from the normal. As the age grows, the atherosclerosis worsen. And if the other risk factors are there will be very soon calcification and total blockage or rupture of the fibrous plaque can occur. So this is the start of the thing, and the end as a total blockage. And presentation as severe chest pain occurs without warning. This is called LEVINE sign. Now look, this person, he has got a central chest heaviness, and he is holding the chest and he is bending forward to relieve the pain. This is called LEVINE sign. Very typical sign, but is not always present. The characteristic pain or the severe breathlessness or the shocked state. This will lead to this if there is a total blockage of the vessel. Now, approach to the patient is that identifying those with chest pain that suggestive of the ischemic heart diseases or acute coronary syndrome. The thorough history required. What happened? Character of the pain, onset and duration, location and radiation, aggravating and the relieving factors, autonomic symptoms, nausea, vomiting, diaphoresis, typical versus atypical history of the person, the failure to recognize symptoms other than chest pain, approximately 2-hour delay in seeking the medical attention. Now this is the chart which is given to differentiate between ischemic pain and non-ischemic pain. Now the type of the pain in ischemia is a dull, is a pressure, is a crushing pain. Non-ischemic, it is a sharp stabbing pain, piercing pain. Or the person can point to the site of the pain. Pointing sign, this is called pointing sign. If there is a pointing sign, there is least chances of the ischemia or angina. The duration in ischemia is 2 to 5 minutes to 20 minutes, less than 20 minutes. The fate occurs in 20 minutes, whether the patient survives or not. But in cases of the non-ischemic pain, it is second to hours. It is continuous pain. It can occur to 1 day, 2 days, 3 days. So it is non-ischemic pain can be of a longer duration, or it may be just a flash of seconds, and it is gone. The onset is gradual. In cases of the ischemic pain, it comes and it escalates very quickly. In cases of the non-ischemic pain, it is very rapid from the very beginning. Very rapid onset. The location is substernal or retrosternal, it is not tender to palpation. And in non-ischemic pain, this is a lateral chest pain or upper part of the chest is involved, or it is tender to palpation at the site of the pain. This pain with the ischemia can be accentuated with the exertion and activity. It will be accentuated. But the non-ischemia, only the turning the body to one side, bending, or coughing, or breathing, or moving will cause more pain. Autonomic symptoms are present like nausea, vomiting, diaphoresis, palpitation, etc. in ischemic type of pain, but they are absent in the non-ischemic pain. Atypical chest pain are risk factors for developing the atypical pain are the diabetes, females, non-white patients, elderly, dementia, no prior history of MI. And atypical symptoms like GI symptoms or syncope or shortness of breath or pleuritic positional pain, chest wall tenderness, no chest pain and symptoms. This is an MRI. 2 studies said that a myocardial infarction without chest pain. This is called painless myocardial ischemia. It occurs in the diabetes mellitus, in cases of the neuropathies, in leprosy, etc. It is very difficult to diagnose. It can only be diagnosed when the patient comes with the left ventricular failure and pulmonary edema. This is can only be diagnosed at that time. Otherwise, you cannot diagnose. Always you will calculate the risk stratification from the age, from the gender, and the other things, the past history, the other things. So risk stratification markers should be calculated. Now this is important here. When you see the emergency, there is a pain in the chest at your home or the primary health care or at the EAE or in the slum area or in the rural area. What you can do is, number one, reassurance. You give oxygen, you relieve the pain, which is the right of the patient to relieve the pain by morphine, by tramadol, by diclofenac. What is available? Give aspirin and clopidogrel sublingually. Nitrates can be given sublingually. If metoprolol is there, you can give intravenous 5 mg if there is no bradycardia. Or you can give 50 mg sublingually if there is no bradycardia. Decide what type of the ACS is now. It is STMI, non-STMI or unstable angina. You do 12 lead ECG and look for the ST elevation in the specific contagious leads. You have to, you know how to read the electrocardiogram. This is I am saying repeatedly. For the ST depression, ST elevations, T wave inversions, T wave flattenings, or new left bundle branch block, for example. So you have to go for the surface ECG, 12 lead ECG, not the monitor ECG. It will not decide the pain of ischemia. Now look, this ECG in lead 2 and 3 and AVF, where inferior wall leads show the ST elevation. It is STEMI of the inferior wall, and their reciprocal changes are seen, that ST depression in V1, V2 and V3. You see here. So this is the typical of ST elevation myocardial infarction. Now this is the typical again of the myocardial infarction in the lead 2 and 3 and AVF. It is again the inferior wall STMI. This is another person who has got the chest pain, but very severe pain with the diaphoresis, everything was there. In V1 and V2 and V3 and V4, there is clear-cut ST depression because the J point is down to 3 to 4 millimeter downwards. Contagious leads. It is the anterior wall non-STEMI. There are atypical type of changes are seen. In this ECG again you will find the V1 and V2 and V3, their ST elevation. This is anterior wall STEMI. Another ECG is shown here in front of you. Look, that is in V1 and V2 and V3 and V4 and V5, their clear-cut ST depressions are seen. This is the non-STEMI of the anterior wall. And there are other ECGs as well, in only the T-wave inversions are seen. Only. With a severe chest pain and there is vomiting. This is the atypical ECG. So ECG has got many things. They will tell you many things. You have to decide the ECG in 0 hours or 15 minutes, 15 minutes, 15 minutes, every 30 minutes. You have to go for the electrocardiogram every 15 minutes. I will do means 4 hourly. There should be 15 and 16 ECGs has to be done. Because of the cost effectiveness in this country, only 3 or 4 ECGs are taken, mostly. At the 0 hours, you have to send the cardiac enzyme. You have to resend the enzyme at 1 hour and then 4 hours. 4-hour enzymes are rarely sent in many centers of Pakistan. These are the recommendations given by the American Heart Associations. What are the cardiac enzymes or the biochemical markers? The ideal markers, the high concentration in the myocardium, because it is ischemia and the myocardial fiber is destroyed. Myocardium is specific, release early in the injury, proportionate to the injury, non-expressive testing. These enzymes are many fold. There are new enzymes are also invented. The most important one are the troponins. Cardiac specific troponin T or cardiac specific troponin I. The other one is CKMB, creatine phosphokinase. But this is the derivative isoenzyme of the creatine phosphokinase is called CKMB. The other isoenzymes of CKMB is CKMB1 and CKMB2. Serum myoglobin, LDH, the ALT, AST. There are other markers. New markers are invented also. For example, BNP, ANP, etc. The only enzyme which are practicable is cardiac specific troponin T, which can last up to 10 days, and cardiac specific troponin I, which can last up till 14 days of the event. So these are the two enzymes which we usually do in our practice. And we see in most of the cases they are positive. If they are positive with the ST elevation, it is called STEMI. If they are positive without ST elevation, it is called non-STEMI. If they are negative with the non-specific ECG changes, this is called unstable angina. Now it is decided that it is STEMI or non-STEMI, or it is an unstable angina, because there is no evidence of enzyme, and the ECG is not suggestive of specific ischemic changes. It is decided now. You should decide. Be confident. Decide it. If it is an unstable angina, what is the essentials of diagnosis? Number one is new onset angina, first time angina in the life. The patient is moving on the stairs, he got severe chest pain or heaviness, and he arrived in the emergency department, and the enzymes are negative, but there are atypical changes. It is new onset angina, it is called unstable angina. Now, second point is stable angina. Angina was diagnosed previously, and he was on the drugs. It may be, and he was stable with the drugs. Now this stable angina is nocturnal, it become nocturnal, it become decubitus, means he is lying down. When he lies down, there is a pain. It is postprandial after taking the meals. Again, it will be labeled as unstable angina. Stable angina, in which the character of the pain now changes, the intensity now changes, duration changes. They are all changed than the previous. Stable angina not responded to the maximum dose of the nitroglycerin or glycyrrhizide nitrate. You give 1 tablet, 2 tablet, 3 tablet after 5 minutes, and there are no response, then it should be diagnosed as unstable angina. Atypical changes seen. I say that the T wave inversions are seen, very, very wide changes, wide T wave inversions. You see in A1 ABL, you see in V3, V4, V5, V6, and enzymes are negative. Now this type of ECG associated with the symptoms is known as unstable angina. Now management of the STEMI is that, first of all, is a reassurance. Say to the patient that you will be safe, no problem, because reassurance will definitely give satisfaction to the patient on the one hand, and there are the chances of the mortality of the disease will be decreased. You have to open the vessel, that is called reperfusion therapy. By fibrinolysis, you have to go for the fibrinolysis. If it fails, you go for the primary PTCA, that is percutaneous transcutaneous angioplasty. If it fails, then you go for the emergency CABG. These are the recommendations of the American Heart Association. And you go for the further management of the patient because of the complications, and give the advice for the secondary prevention and management of the complications associated with the ST elevation myocardial infarction. Now fibrinolytics are available. Streptokinase is usually used, which is a cheap drug. The other drug is the RTPA, tissue plasminogen activator. It is a costly drug. Another costly drug is NSTEMI. Another one is the tenecteplase or retelplase. These are available in some of the hospitals in Karachi, but they are very costly drugs. Now, you give the fibrinolytics, it will work. And in front of you, the ST elevation will definitely go down as the time passes. If it fails, you give the second dose of the streptokinase or RTPA. If it fails, then you go for the primary PTCA. If it fails, then you go for call the surgeon and go for the primary CABG, coronary heart bypass surgery. As far as the management of the non-STEMI and unstable angina, they are the same. First of all, reassure the patient, admit the patient in ICU, give the oxygen 2.5 liter per minute continuously, give metoprolol intravenously, relieve the pain by giving some drug. Morphine is the ideal drug, or tramadol or other. give glycite nitrate or mononitrate, dinitrate intravenously. When you start the anticoagulants, you give the heparin or the low molecular weight heparin, like enoxaparin, etc. And it will relieve the problem with this patient. According to the American Heart Association, if the patient is relieved, you do coronary angiography now after the patient's symptoms subsided. For example, after 24 hours, and do coronary angiography. And if it is positive, then decide whether the patient will go to the CABG or PTCA, British or European Heart Association or coronary societies or cardiac societies. They do coronary angiography after third week. After third week, they do the ETT or thallium, and then they decide about the future of the patient, whether they will go for the PTCA, that is the percutaneous transluminal coronary angioplasty, or CABG, that is coronary artery bypass surgery. They decide afterwards. I follow HAHA planning, which is supported by the American Cardiac Society and Canadian Heart Society. This is a good approach to the patient. They have, if you save the myocardium to destroy as least as possible, you follow the first one, that is do coronary angiography when the patient is asymptomatic. Now, a common case scenario for a 56-year-old businessman, non-hypertensive and a type 2 diabetes, arrived in the primary care setup with a central chest pain of the severe intensity for the last half hour. There was history of vomiting, headache and sweating at the onset of the pain. He smoked 20 cigarettes per day since 35 years and on glimepiride, metformin and valsartan since 1 year. On examination, the blood pressure is 170 by 100, pulse 90 per minute. Heart sounds are normal in intensity except in the aortic area where S1 was loud. ECG was done and there was left axis deviation and evidence of the left ventricular hypertrophy. There was no evidence of ischemic changes on ECG. The random blood sugar is 310. Cardiac enzyme sample were sent and they are awaited. Now, the question number 1 is, from an above scenario, the most likely diagnosis would be the dissection of the aorta, acute myocardial infarction, pleuritis, esophagitis, and Stevens disease, that is costochondritis of the chest wall. Answer that question. Question number 2 is, if the most likely diagnosis is acute coronary syndrome, for example, if you diagnose ACS, which is the most likely investigation which can be helpful at its earliest? ECG, CT thorax, cardiac enzyme, thallium scan, or echocardiography. Which is the best one at the earliest? Earliest diagnosis, diagnostic clue. Question number 3, choose from the following therapy or therapies which are beneficial for this patient at the primary care setting. Choice may be multiple. Number A is sublingual nitroglycerin, B is sublingual aspirin, C is sublingual captopril, D is oxygen, E is sublingual nifedipine, F is intravenous morphine or pentazocine or pethidine, G is sublingual clopidogrel, H is intravenous metoprolol. Choose 2, 3, 4 as you want. Question 4 is, the report of the cardiac specific troponin T was still awaited, but the ECG was repeated and showed now the left bundle branch block in V4, V5, V6 leads. The most likely diagnosis is now the stable angina with the left ventricular strain. It is actually the AMI, the acute myocardial infarction, although it is non-STEMI. C, non-Q wave infarction. D is prismatic angina. E is subendocardial infarction. That is, the infarction occurs in the very near to the endocardium. At one time it is the subendocardial infarction. It is a part of the NSTEMI, It is a part of variant of STEMI. Question number 5 of mine is for you. After 2 hours, cardiac specific troponin T was found to be positive. Now it is positive. Now your diagnosis will be prinzmetal angina, non-Q wave infarction, acute myocardial infarction, unstable angina, or drug-induced myocarditis. Acute myocardial infarction, here I mean NST, the ST elevation myocardial infarction. Which is the choice? Sixth question is, the most likely therapy would be coronary angiography followed by PTCA, reperfusion with the streptokinase, thallium scan followed by CABG, general measures and strict glycemic control, and lastly heparin and intravenous nitroglycerin. Choose one, which is the best option. So this is the case which I have presented in front of you, the second case. And there are 6 questions I have put